critical care. So we know the vitals, which is very much important in our day-to-day practice. Remember, in our history writing for the times of the MBBS period, we have to take the vitals. And it has been known after particularly the COVID epidemics, the new onset diabetes mellitus and the person who are going to be non-diabetic hyperglycemic patient is marginal. And that's why the measuring blood sugar in the blood glucose form is essentially very important into our practices. So here I will go in brief journey of hypoglycemia. So what is hypoglycemia? As you all know, that there is traditionally defined biochemically as plasma glucose of less than 63 milligram per dl, which has been now set less than 70 milligram per dl according to the international study group. And what happens? It is an impaired cognition, cardiac arrhythmia, and increased mortality rate. So the level 1 or level 2 blood sugar hypoglycemia is not a major concern for us, but which is much more concern is the level 3 hypoglycemia, which I am coming later on. And what the blood sugar monitoring vitals. Suppose we are sitting here in before 1970 and we do not have any measurement policies here. And we have the urine sugar or the substance reduction measurement that is known as the Benedict test. And the first blood sugar monitoring scale is 1969 to 70 and first portable blood sugar meter just weighted nearly 1.2 kilo. And then from the journey goes and it has come to the blood sugar monitoring regularly and the self-monitoring of the blood glucose SMPG, and this term has been omitted by the IDF in 2020 in favor of blood glucose monitoring or the BGM. And next, the most important one is the continuous glucose monitoring. And what happens is level 1, level 2 and level 3 hypoglycemia? The hypoglycemia alert. That means this is not the hypoglycemia per se, which it alerts us that when the blood glucose level is less than 70 milligram per dl and it is a lower limit of the glucose in range of the GIR. That means it is usually asymptomatic, it will prevent hypoglycemia and is considered regimen changing which is recurrent. That means patient may not experience the signs and symptoms of the hypoglycemia itself, but it gives give an alert to the clinician or the physician that you should be alerted and we have to alter the regimen if the patient is already on, particularly on the insulin or the sulfonylurea group of drugs. And later, the level 2, which is much more important, and study has been said that clinically important of less than 54 milligram per dl. And this is associated with impaired cognitive function or the neuroglycopenic symptoms and predicted severe hypoglycemia and also risk of cardiac arrhythmia, and that's partly leads to mortality. And later, the level 3, here, any amount of the blood glucose less than 70 milligram per dl, even it may be the 69 or the 34 milligram per dl, but that has shown the cognitive decline where support from another person is required. And this episode requiring parenteral therapy, loss of consciousness or the seizure, and that is indeed a medical emergency, and we have to recover the patient at immediate on spot, even by the IV glucose infusion, if not possible, then by any kind of glucagon formulation available in the market. So, the symptoms like the severe hypoglycemia, as I have mentioned earlier, it is a less than 70 milligram per dl, but no lower limit of any level has been fixed to it. And the neuroglycopenic symptoms is a hallmark of it, and the neurogenic symptoms is most likely present. And what the documented symptomatic hypoglycemia, that is the symptomatic hypoglycemia that is documented. Patient experience both the symptoms and the documents of less than 70 milligram per dl, and patient may have symptoms of hypoglycemia with the neurogenic symptoms. So this is the basic difference between the hypoglycemia alert and the documented symptomatic hypoglycemia. And what is asymptomatic hypoglycemia? That means with a percentage of less than 70 milligram per dl, patient is absolutely fine. You give an alert to the clinician, but not need to be treated if it is a healthy one. It may be the diet modification and also the regimen changes. And the probable symptomatic hypoglycemia, likely low but not confirmed by TLC. Sometimes the patient comes to us and says that I was getting some dizziness and I took some sugar salt and I checked it in the home and it finds more than 80 milligram per dl. So we don't know whether it was a really or not really hypoglycemia itself, but according to this classification, we can put it in the favor of the probable symptomatic hypoglycemia. And the pseudo-hypoglycemia, I will come in later on. This is a very important topic in our critical care practice. So, just going back to the causes of the different cases of hypoglycemia, I would like to focus on the last two parts, the adolescent and the all ages, which are much more concerned to us. And this is, in adolescent group, one is first-time appearance patient who is not responding with the clinical, in the usual pattern, hunts to have taken insulinoma or the adrenal insufficiency or sometimes with a hypopituitarism. And all ages complications of type 1 diabetes, sepsis, congenital heart disease, and the tumor and also the adrenal insufficiency, apart from the iatrogenic one. So, what is the management of the hypoglycemia in adult? So, first, the frequency of the hypoglycemia. At a study which is published in NCM, has shown that 2 times per week episodes experienced by people with type 1 diabetes and a 5% hospital admissions due to the hypoglycemia in people with type 1 diabetes. And 1.5% has been attributed to the hypoglycemia in type 2 diabetes, and the 30 to 40% of the annual prevalence of severe hypoglycemia in unselected population. This is a study done in the USA. And the management, going to the, in briefly, what to do and what not to do. So what not to do is much more important because we know that what to do in most of aspects. And don't avoid driving or eating with some things like the heavy protein diet. Sometimes we take a chocobar or the high protein or high ready-made calorie, but that is a fatty meal which actually prevents the absorption of the simple glucose which is reactant for this hypoglycemia. And so we have to do the 50-20 grams of the fast-acting carbohydrates available at a 4 gram of the glucose or dextrose chewable form, and check blood glucose level after 15 minutes of it. If it is low, then repeat the treatment till it gets normal, at least 3 times. And if the blood levels are low, a close friend or relative can recognize the low blood glucose and can provide a dose of glucagon which immediately stops symptoms. So this is the most important. Look at this point. This is a suggestion by the IDF that even a non-medical person, they should be trained when a person who is very much symptomatic or the very much high verge of the type 2 diabetes, type 2 or type 2 failure should be provided with a shot of the glucagon irrespective of his clinical or the training status. So after a person is there, give the fast-acting carbohydrates as I have mentioned earlier. So the management in the hospital, different approach for the reducing hypoglycemia in the hospital, that have to be 3 types. One is the human approach and the computerized approach and the continuous subcutaneous insulin infusion. So I will go first into the human approach that identify the amount of the carbohydrate consumed, and this can be using by the wave-linked glucose meters and enhanced diabetes team and diabetes training for the non-specific medical term. So nowadays there are many regimens which can predict directly the amount of the carbohydrate and the amounts of the insulin needed to utilize this amount of carbohydrates. And there is the web-based regimen is available even freely in the internet. And the computerized approach, we know that nowadays this is the era of the artificial intelligence. And this computerized approach, in order to identify the highest risk of patient of hypoglycemia, the data of the patient can be included, which is available by the continuous glucose monitoring PBS. So this is a web-based or the CGA, which is standardized against the software that is developed in 2019 IDL with collaboration of some companies in US. That is standardized that the patient performing approach of the computer, the best performing algorithm which utilize data from the patient and it tally with the recorded regimen, and it tells that when you are going to develop the hypoglycemia. So likely days, one day will come when the Alexa will say that with the next 1 hour you will going to the level of hypoglycemia, so please take a snack. So the management is quite straight-cut. I am going to the moderate and the severe one, which is much concerned about us, and the patients are conscious and able to swallow but confused, disoriented or aggressive. Then we have to go for the basic line, that is the checking airway, bathing circulation, as you all know. And then we have to go for the glucose control and the blood glucose measurement and exposure, and stop IV infusion if it is already running. And if it's the patient the severe one, then we directly go 100 ml of 20% dextrose or 200 ml of 10% dextrose over 15 minutes. And if it is the patient is conscious and can take oral food, then we have to give the 15 or 20 gram of the quick acting carbohydrate. And what else? The blood glucose level after 10 to 15 minutes check, and if it is still less than 4 millimole per liter, or 70 milligram per DL, then it is repeated up to 3 times, it becomes normal. And do not omit the subsequent insulin dose. This is the most common error in our practice. When a patient develops, say, level 1 or level 2 hypoglycemia, it is a usual question that what we will do for the next dose of the insulin. We usually suggest to reduce 20% of the required dose, but don't omit the required insulin dose. We may have to modify or to review the insulin and the oral hypoglycemic regimens, but never to stop it, and never to give a stacked dose of a short-acting, say, or rapid-acting insulin to keep the spike. This is and if the patient is previously on the IV insulin, then consider restarting insulin once the blood glucose is stable after 3 days at least. So the measures to be taken in future when hypoglycemia is treated successfully. The most common cause of the hypoglycemia or etiology of the hypoglycemia and admission into the hospital is the hypoglycemia event itself. It is called hypoglycemic unawareness. If a patient has been experienced in our ICU or in a critical care level 2 or 3 hypoglycemic events, it is the most important etiological factor. For the next 2 to 3 weeks, he or she may appear with the same episode. And this is known as the hypoglycemic unawareness, and we have to be cautious at least for 2 to 3 weeks to maintain the patient's blood glucose even on the higher side of blood sugar monitoring. So do not treat isolated spikes of the hyperglycemia with stacked or doses of the rapid-acting insulin. Instead, maintain the doses of the insulin or the sulfonylurea and do regular monitoring with at least 15 to 20% of the reduction dose of patient's usual regimen. So the management of the hypoglycemia in elderly, it is quite same as all patients, but the important thing that if the patient is not conscious, don't go for any kind of IV dextrose rapidly, but give the glucagon if it is available intramuscularly or the nasal glucagon if it is available in the market to give it. The most important thing now, the Canadian Society of the Geriatric Medicine and so also the American Society of the Geriatric Medicine recommends that the higher side of the HbA1c is 7.5%, particularly of the patients of 65 years of age or more in type 2 diabetes mellitus patient, and they should be treated particularly with the metformin or other newer GLP-1 agonist to avoid the level 2 or 3 hypoglycemia. So the ADA target of less than 6% has been shifted against the 7.5%. So these are the general measurement and drugs which are management of the hypoglycemia. Metformin is a drug of choice even today for the newly diagnosed, and SGLT2 inhibitors should be used in combination with insulin monotherapy that increases the risk of hypoglycemia. And modern sulfonylurea, glyclazide and glimepiride has the lower range of the hypoglycemia compared with the conventional second generation, as you all know. And GLP-1 receptor agonists, also DPP-4 inhibitors, has a tremendous low tendency of the hypoglycemia when they are using alone. And this is a study where the 52 weeks randomized parallel arm open label study with HbA1c of more than 7% and a 77 for type 2 diabetes men patient has been followed. And they have shown the next data that the highest level of the hypoglycemia, level 3, has been achieved with the person who were on the metformin plus basal insulin rather than the metformin plus sulfonylurea. So the take-home message is that till date, the insulin-based regimen plus minus with the oral antidiabetics, higher on the sulfonylurea, is the highest risk of the hypoglycemia level 2 or level 3 in our clinical practices. And in sulfonylurea, glibenclamide, which we rarely use nowadays, has the highest mortality rate than the glimepiride. And in our critical care unit, we frequently put the patient on other medicines like the clarithromycin or the warfarin, which has causing the propensity of drug interaction and the hypoglycemic events. So I'm running short. So these are the drugs, the glucagon, stable solution, and the desiglucagon and the synthetic forms. They may be used, and this is the chart where every intranasal glucagon, subcutaneous glucagon, or the traditional glucagon, more or less they are same. The take-home message is that we have to use what is available in our hand. And the different scenarios. The nocturnal hypoglycemia, I have mentioned it. This is the most notorious because it can lead to death in bed syndrome due to the prolonged hypoglycemia. and particularly very difficult to treat, and the treatment is the open loop sensor augmented pump therapy or sensor augmented pump therapy for the multi-dose intrasur, and the artificial pancreas is the last one for this. So these are the computer-based algorithm, the SBR model that designed that this is in favor of much more propensity to reduction of 94.1% of nocturnal hypoglycemia than to comparison with the single dose of simple peptide glucose HT. And a different scenario, most important is the Ramadan. A PDR study has shown all forms of hypoglycemia increase in people fasting during the Ramadan, and that the guidelines prevents or at least forbids the pregnant women and the children to practice this fasting. And when if you want to practice it, then we have to use the insulin pump instead of the multiple day insulin injections. And recommendation during fasting is the more or less same. And this is the pseudo-hypoglycemia, the picture right depicted below, a person with actocyanosis, the patient having a blood sugar level of 26 milligram per dl, but patient was healthy. And when a contemporary blood level drawn from his central line, it has shown that 326, already he has taken 2 shots of the glucagon and 3 bouts of the 10% dextrose. So the take-home message for this pseudo-hypoglycemia that we have to denounce what is the true hypoglycemia. And the pseudo-hypoglycemia causes, I'm not going to mention all these things, but actocyanosis and some kinds of leukemia and erythroleukemia and also factorial error and the tissue fluid measurements are one of the causes. So the management is quite straightforward, and most important is the education and the support and the monitoring blood glucose level properly. And the take-home message here that the self-management education, mild to moderate hypoglycemia can be treated with the oral 50 to 20 gram of quick-acting glucose, and IV dextrose or the IM glucagon can be given for the severe hypoglycemia. And this IV glucagon can be given even by the non-trained person who are the caregiver for the type 1 diabetes mellitus or the friend type 2 diabetes mellitus patient, even with a non-medical background. And insulin should be continued if blood glucose is controlled. Never stop it. Reduce it, but don't stop it. And alterations of the drug therapy, including oral hypoglycemic agents, are recommended to reduce and prevent hypoglycemia. We can shift our regimen to the newer one. We have plenty of multiple oral antidiabetics which are less propensity of hypoglycemia, and special precautions should be taken while fasting, and recommendations should be followed as per the guidelines. So that's all. I leave you here for the next journey of the hyperglycemia. Thank you.